With GUPTA, is he there? Yes. He is going to speak on outcomes of Bang, KDB and Tanito in Indian eyes.
Good morning, everyone. My paper is Outcomes of Bang, KDB, and Tanito Goniotomy in Indian eyes. Glaucoma is a leading cause of irreversible blindness in the world. 76 million people in 2020 were suffering from this disease. This number is expected to rise to 112 million by 2040. In India alone, 12 million people are affected by this disease. In cataract surgery, we have moved from couching in 6th century to ECC and ICC of 18th century to SICS and FACO of 19th century. Is it similarly time for us to add MIGS in our armamentarium? Minimally invasive glaucoma surgery are safe as they provide quick recovery and reduce medication use. They promote natural drainage by minimal tissue damage and are a safer alternative to trabeculectomy. MIGS can be trabecular bypass stent like iStent and Hydrus microstent, suprachoroidal shunts like Miniject, ab interno trabeculotomy like Bang, GAT, KDB and Tanito, ciliary body treatment like micropulse transscleral laser treatment. So what was our study about? We found out that there is limited mixed data on Indian eyes. So with the objective to evaluate Bang, KDB and Tanito hook in effectiveness in Indian eyes, we measured IOP, anti-glaucoma medication reduction and success rates of these procedures. We did a retrospective chart review of 90 eyes which had underwent mixed with phacoemulsification. We took 30 patients in each of these groups and we took patients with follow-up of minimum 3 months. These were my inclusion and exclusion criteria. We collected data like Tmax, which was the maximum intraocular pressure recorded before starting any anti-glaucoma medication for each patient. Post-operative intraocular pressure was measured on POD 1, 7, 30, and 90. Visual acuity was measured on each visit. Number of active ingredients in anti-glaucoma medication were measured preoperatively and postoperatively. Severity of the glaucoma was measured based on the vertical curve disc ratio. Any complication intra-op or post-op were noted. So, at baseline, the mean age of all the groups were comparable. The male to female ratio was 2:1 in all the groups. By far, primary open angle glaucoma was the most common diagnosis in our study. Most of the patients were mild to moderate glaucoma in all the groups. All the patients were at least on one anti-glaucoma medication before undergoing the procedure. The preoperative Tmax was comparable in all the groups. We categorize our outcomes as failure if the IOP was greater than 21 millimeter of mercury on 2 follow-ups after 3 months, if IOP was less than 5 millimeters of mercury on 2 follow-ups after 3 months, if it needed glaucoma reoperation, or there was loss of light perception in that eye. We called it as qualified success if it was not a failure or IOP was controlled with AGM. And it was called as complete success if it was not a failure and no AGM was needed. We saw that from compared to preoperative Tmax, the IOP reduced in all the groups significantly. Also, AGM use reduced down to 0 AGM in majority of the patients in all the groups. Coming to complications, KDB group had no complication. Bang group had 1 complication of excessive bleeding. Tanito group had 2 complications, one of an iris injury and other was a PCR which was not related to the procedure. Coming to success rate, KDB had by far the most successful success rate of all the procedures. Coming to discussion, Bang had good efficacy. Our results aligned with Bouquet and et al. Studies. Complications were low. We had fewer complications. Learning curve is considered to be short for this procedure. In terms of cost consideration, it is considered low. Thus, it is mix of choice and resource-strained settings. Coming to KDB, KDB had the highest efficacy among all the groups. Our study aligned with Wagner et al. And Vasu et al. Studies. The complications were least as there were no reported complication in our study. Learning curve for this procedure is considered to be short, but in terms of cost consideration, KDB is an expensive instrument, thus it is can be prohibitive for outreach settings. Coming to Tanito, our results aligned with Maheshwari et al. Studies. The efficacy was good. In terms of complications, it was low. Learning curve for this procedure is considered to be shortest. In terms of cost effectiveness, it is a reusable device, so over the period of time it will be cost effective. Availability of the instrument is currently limited in India. Coming to our limitations and prospective future research, the study was a retrospective study, thus, and a short follow-up was there, and there was a small sample size. Future research can be done for prospective study, longer follow-ups can be done, larger multi-center studies can be done, and comparison with traditional surgeries have to be done. Key takeaways are that KDB had the highest success rate with least complication, but it is expensive. Bang had low cost, effective mix for resource strained settings. Tanito hook is reusable, so it is cost effective over time. In conclusion, MIGS is a safe and effective alternative treatment modality for glaucoma treatment in Indian eyes. Thank you.
Thank you, Arpit. Good paper. Tell me, they were all standalone mix? None of them were combined with FECO?
All of them were combined. They were
all
mixed
FECO
with,
something.
FECO mixing.
And the other thing is, any reason to use a Tanito hook if it's the same as a bang? Why would somebody invest in that if you're saying they're both safe and it'll be effective over a long time, but this is effective in every case?
Yes.
Any inputs as to the difference between bang and Tanito hook? If I want to buy a Tanito hook here, why would I buy it if I asked you?
As such, ma'am, currently.
There's no difference.
Yeah.
Okay.
Okay, results are only 3 months, isn't it?
Yes, ma'am, 3 months only.
So that's really rather short.
Short period, right?
You
Yes.
need to follow up longer.
Yes, ma'am.
And,
Yes, ma'am.
Thank you.
Also, the inferential statistics for the demographic baseline that wasn't shown. It's all descriptive.
Okay.
Whether the groups are comparable.
Comparable or not, yeah, correct.
Okay, thank you, Dr. Gupta.
Any
Our
complications
next
were not
presenter.
reported in the
Okay,
KDB.
yes, okay, sorry. Please.